All right. Before I begin, I see that maybe we have a couple of new faces in here. I just want to, get a sense of how many of you have a background in neuro image processing or anything to do with CT. Um, okay. Oh, it's good to know. I just want to get started by saying that domain knowledge is indispensable in any kind of data analysis, especially when you're doing machine learning or AI. And CT is definitely not an exception for that. And through this session, I want to give us all a good sense of the basics of how CT is acquired, what different neuroanatomy that you can visualize on CT are, and what are some markers of neurodegeneration. I hope that through this, you're able to appreciate structural neuroimaging processing and also take away something for your own research. So let me just get started with the agenda for today. So I'm going to go over the brief motivation of why head CT is important in neurological healthcare, and then I'm going to talk to you about how CT is acquired and reconstructed. After that, we're going to take a neuroanatomical tour on head CT. I hope that'll be insightful. And we'll look at how the diseased brain looks on CT. And at the end, we'll have time for questions. So, okay, let me just dive right in. The focus of this special session today, which is meant to be an educational session, and if you're going to stick with us for the rest of the day in the afternoon, we're going to have some hands-on tutorials. And the focus of the entire day is non-contrast CT. And, this is ideal in emergency situations when you have head trauma, stroke, hydrocephalus, or tumors or infection. All of these conditions have acute symptoms, and CT is ideally used for these situations. But what people often forget is that chronic degeneration like atrophy is also revealed on CT, and unfortunately it's sidelined as compared to magnetic resonance imaging because of superior resolution. But what's interesting is that there's a global increase in the number of CT scans that are acquired. In the US, for instance, in 2016 alone, there were 23.6 million head CT scans that were acquired. And the Veterans Affairs data suggests that we see CT scans acquired at a rate which is 4.5 times that of head MRI scans. Now, there is this concern about radiation dose in CT, about radiation being a carcinogenic, but due to technological optimization, we have been able to decrease the radiation dose that's required to get CT images that are equally high in quality. And radiation dose is often a risk in younger children as compared to older adults. And I think overall, the use of CT has more benefits than risks, especially as it's also more accessible as compared to MRI. It's cheaper, it's quicker, and it has fewer contraindications. So just quick background, CT is acquired with X-rays. High energy electromagnetic radiation is passed through the patient body, and then as it gets attenuated through the differently dense tissues, we capture the attenuation at a detector and then visualize that difference in attenuation. And this is within 3D pixels or voxels. So this is a very basic schematic of how a CT scanner looks. So just at the beginning, you obviously have your X-ray tube. Now your X-ray tube is going to be your energy source. It has the basic cathode-anode composition. And it's very important to understand certain aspects of the CT scanner if you're doing any kind of data analysis with CT, because there are several factors which are decided right at the beginning when the CT image is acquired, which impacts image quality. And if you don't account for it when you do your data analysis, then you're going to either end up missing true signal or you might end up capturing false signal. So right at the energy source, you have a tube current and tube potential, which basically decides how many electrons you have which generate the X-ray and then how quickly they're accelerated. And the higher the tube potential, you have more radiation, the higher radiation quality, and you have better and crisp images. Next, you have your filter, right? If you look carefully at the shape of that filter, it looks like a bow tie, and it complements the patient's body distribution. So the patient is thickest at the middle, and then the weight tapers off towards the side. And the shape of that filter is exactly complementary to that. And the reason why the filter is designed that way is because if you have radiation passing through a thicker part of the patient, you're going to have more attenuation. And at the bottom, like, or the posterior side of the patient, you're not going to have enough radiation to create an image which is equally resolved as you would see at the top of the patient. So this filter is designed in such a way to make sure that it pre-attenuates the X-ray before it reaches the patient, in such a way that it complements the patient's body shape exactly, and you don't lose image quality. Then you have the collimator, which is basically a beam focusing or beam shaping structure. What that does is when you have your X-ray beam being projected onto the patient, you're going to have some scatter in the Z direction, so in the superior inferior direction of the patient's orientation. And if this scatter is not limited to a particular slice, because remember, CT images are captured in slices, and if you have scatter coming in from other slices, you will have interference, and you're not going to end up imaging what you really need. So this collimator prevents scatter in the Z direction. And finally, most importantly, you have the detector, which is what captures the attenuated beams. So you have a scintillator which converts the attenuated signal into photons, and that is converted to electrical signal using photodiodes, and then they're digitized. Now, this detector has specific detector elements, and how far apart they're situated, decides your image resolution. And you also have an anti-scatter grid in the detector, which prevents scatter in plane. So going back to what we talked about, the collimator, that prevents scatter in the Z direction, whereas you have like an anti-scatter grid within the detector array, which prevents scatter in plane. And then all of this equipment is housed in what is called the gantry, which rotates around the patient. And you're also able to tilt this gantry to avoid exposure to sensitive areas like the eyes. And the patient table, which obviously carries the patient, it moves through the gantry as the gantry rotates around the patient. And you're going to get attenuation values at different radial locations and translations. So if you caught all of that, as we discussed, the gantry rotates around the patient, and then the table moves through the gantry, and you're going to capture attenuation in different regions. So what your detected signal looks like is what you see on the top left. That is called a sinogram, and you're going to, that's what it's going to look like. On the x-axis, you have the angle of rotation. On the y-axis, you have the detector position, which shows the distance of the object of interest from the detector. Now, there's, how do you make sense of this? Where's the organ that you want to image, right? So if you look at the path that I've highlighted, is anybody able to tell me what that corresponds to in the image that's at the bottom, where you see like a bright signal going through? Yeah. Yeah, you're right. Yeah, it's basically the highly dense bone that's captured there. So this process of converting your sinogram into the image, it's called filtered back projection. That's what's commonly used. And we're going to talk about how that works in just a second. But there's also better methods to reconstruct your image from the sinogram, which is what you see in the next two columns. So there's something called back projection, wherein you have filtering in the specific domains. So you've got filtering in the sinogram domain and filtering in the image domain, and they don't interact. But what gives us the best resolution is model-based iterative reconstruction, where you have feedback from the sinogram to the image domain, where this is performed iteratively, and you have really good resolution and crisp images. So, we talked about what back projection is used for, and you generate your image from the sinogram, but how exactly does it work, right? If we go back to high school quickly, we've all solved a system of linear equations. So in this situation, for instance, you have a matrix in the middle, and you've got 16 variables. Imagine that represents your patient's body, and you want to estimate what the attenuation values are at each of those 16 levels. What you do is you pass radiation to the patient at two different angles, orthogonal angles, as I've shown here. So that gives you 8 equations and 16 variables. Now, we all know this is an underdetermined system. You're not going to be able to find a solution to this. And when you look at a typical CT plane, you're going to have something like 512 by 512 pixels. That's a highly resolved CT plane. Now, if you need to determine all these variables, how many samples do you need? If you have a 512 detector array, you're going to need at least 500 samples acquired from unique radial locations. So that's basically what underlies computed tomography, wherein you acquire a lot of attenuation samples at different radiation angles and essentially solve a system of linear equations. And it's not going to be possible for a human to do, and a computer does it, and hence the word computed tomography. So we, just by looking at the image on the right side, imagine that what you want to image is what is shown at the top. And with back projection, you do not get really crisp images by solving the system of linear equations. In other words, you're going to get something that looks blurry, and you will need to filter it in the image domain, and that's where the word filtered comes into picture. So this is basically the essence of filtered back projection. It takes us from the sinogram domain to the image domain, and you're going to end up getting densities, which are represented as Hounsfield units, and that correlates directly with what kind of tissue it is that you're imaging. So I want to quickly share something that I was thinking about recently and get your opinion on this. So we saw how sinograms look, and they represent upstream data, right? And we all know that with machine learning, it's really sometimes nice to have unprocessed data and work with more upstream data. Why is it that we are so focused on working with the image data, which is human interpretable? Like, is that something, this is something that I was just pondering on. I was wondering if anybody had any opinions on this, or like maybe if there is something that in your field that a similar case like this, where you have more unprocessed upstream data, and if you have a machine learning application particularly, wouldn't it be better to use that rather than working with reconstructed data, which is reconstructed in such a way that it's mostly interpretable to humans? Anybody? So just to share what I found in 2019, actually, there was a paper which did exactly what I was suggesting, which is they used the sinogram data without image reconstruction for intracranial hemorrhage detection and body region identification, and they found that it performed better than using reconstructed images. So there's probably some kind of utility to that. But again, in my opinion, I think we are very far out from relying completely on upstream unprocessed data for tasks like medical image segmentation, for instance, because it's so closely tied to human interpretation and radiologist interpretation. So I just want to show what a basic CT image looks like, because we've been talking about how they're acquired so far. This is a CT scan of a patient with normal pressure hydrocephalus. You see that on the top left corner, there's an axial acquisition, which is acquired in the inferior superior direction. You can orient yourself by looking at the human figure icon next to it. And then at the bottom, on the left side, you've got a coronal reconstruction. And then on the right, you have a sagittal reconstruction. Now that we've gone over some basics of CT acquisition, I just want to stop here and see if anybody had any questions before I move on to the next section. Okay, looks like we're good. Let's just move on to a neuroanatomy tour on CT. So these are, again, basic CT interpretation objects. So you have the Hounsfield unit, which represents the density at each voxel. As you can see on the right side, it's the scale is built in a way such that water is your reference. It's 0 Hounsfield units. And then the higher, the more dense your tissue, the higher the density the Hounsfield unit is going to be. So air is negative 1000, because it's the least dense object that will be imaged. And then you have cerebrospinal fluid that you see marked on the right side, where the Hounsfield unit is going to be less than 15. And I've windowed this scan in such a way that it's easier to spot the gray and white matter contrast. So if you look at the previous image that I showed, right, it's really hard to differentiate between white and gray matter, whereas here you can kind of see at the corner of the brain or at the surface, you see the gray matter, which is more dense as compared to white matter. And then if you have acute blood in your scan, it's going to be about 80 Hounsfield units. And bone is usually going to be the most dense tissue that you'll image. And if you have metal implants, that'll be the highest density, and they often cause artifacts even. Okay, so now I'm going to take us through an anatomical tour on CT, and we're going to go in the superior to inferior direction. So one of the most prominent things that you will see on CT, and which is used very frequently, is for orientation, is the midline. And what defines that is the fox. Now that's the folding of the dura mater, which descends down in between the hemispheres of the brain. So that the dura mater is the toughest meninges we all remember from biology, and how that looks on CT is like this. You can see it bright and right in the middle of the axial view, separating your hemispheres. And it's often bright and gets more calcified as patients age. So it's used in defining the ideal midline and patient orientation. Now, anything above the tent-like structure that you see in this image on the left is called the supratentorial brain, and anything that's below it is the infratentorial brain. Moving one step lower, we all remember the lobes of the brain. You can see that I have imaged the region which is enclosed in this red rectangle that I've shown on the left. So, on just focusing on the axial view, which is the topmost image, you can see the frontal lobe and the parietal lobe responsible for executive motor function and sensory function for the most part prominently. And this is what you can view at the superior slices of your CT. And what separates that is your central sulcus. What you'll be looking for is this reverse omega-like sign, which allows you to locate yourself in the brain. So that separates your frontal lobe and the parietal lobe. And you can see the same on the sagittal reconstruction on the right side. Now, you'll notice that the resolution is not as good in the coronal and sagittal reconstructions as compared to the axial reconstruction. And that's because I've just reformatted the axial volume. Now with CT, you also have, in most cases, you also acquire coronal and sagittal reconstructions, which are highly resolved. But just in this case, I've not demonstrated that. Now we go again lower in the brain, where you have the longitudinal fissure that will take the place of your fox, right? So this will be the space which separates your left and right hemisphere. And then on the image in the left, on the 3D image in the left, you can see where the lateral ventricles are, which are one of the most prominent bodies that contain cerebrospinal fluid in your brain. And what you see in the axial image is basically the lateral ventricles, which is split into two halves, the frontal horns and the occipital horns, because they extend back into the occipital lobe. And then you've got the frontal and parietal lobes, which we saw in the previous slide. And you've got the prominent sulci, which separate your occipital lobe from the parietal lobe, and the occipital lobe from the infratentorial space, which correspond to the parieto-occipital sulcus and the calcitrine sulcus, respectively. Next, I want to show some anatomy, which are very crucial, including basal ganglia, that are often, probably overlooked in CT, in the sense, overlooked in the sense of performing data analysis, because as you can see, the ventricles are the most prominent anatomy, but you can also visualize several important anatomies that I've highlighted here. You can see the frontal horns of the lateral ventricles that we saw in the previous slides. And then this Sylvian fissure that I've highlighted next is what separates your frontal lobe from the temporal lobe. And this is also another important landmark in the brain, as we saw with the central sulcus. Now, the Sylvian fissure becomes extremely important to analyze, because in conditions like normal pressure hydrocephalus, you have the Sylvian fissure, which is expanded. It's a telltale sign of NPH. And at the same time, you're going to have the midline really compressed. And so it becomes important for us to be aware of which anatomies to look for. Next, you can see this bright structure on the two bright spots on the left and right hemisphere. This is often confused as acute blood if you're not aware, but it's not acute blood. This scan is from a patient with a normal patient, so there's no pathologies. It's bright because this structure called the globus pallidus, which is part of the basal ganglia, is calcified, and as patients get older, it gets more and more calcified. And that's what you notice there. Then you have your third ventricle. So your CSF flows from the frontal horns to the third ventricle, and it's usually a slit-like appearance right in the middle. Also helps you orient yourself, also helps identify where the midline is. And if you notice inside the occipital horns of the lateral ventricles, there's a bright tissue which corresponds to the choroid plexus. Now, these cells are what produce cerebrospinal fluid in your ventricles, which performs a lot of functions, protective functions, and metabolic helps in metabolic functions for your brain. And then what's obvious is the thalamus, which is also at this level. Now, the thalamus is it's a router which routes which signals go to the brain and get processed, and which signals do not. So you also notice the thalamus on this scan. And you can also see the temporal horns of the lateral ventricle, which are in the posterior side. So the lateral ventricles basically have, importantly, the frontal horns, the temporal horns, and the occipital horns. So if you look, now we're going further down in the brain. If you look here, there's a friendly Mickey Mouse peeking at you, which is the midbrain. And you can see that it's the first level of your brainstem. As you notice the red line in the sagittal view, you notice it. Now, the midbrain is really important because it houses your dopaminergic cells. And if there's a depletion in those, it leads to Parkinson's disease. So it becomes important to be aware of which anatomy, have like opportunity to be analyzed on CT for particular diseases. And then you have the temporal horns of the lateral ventricles, which you saw in the previous slide, just slightly, tapering off in the slice. And you have your temporal lobe, which extends downwards into the inferior side of your brain. And you have the pineal gland that's visible in the sagittal view, which is like brightly calcified. Now, what the pineal gland does is it produces melatonin, which helps you sleep better, and and it also helps in standardizing your brain. So I talked about how the fox is really important in identifying the midline and standardizing the brain. Similarly, the pineal gland is also a very bright and easily identifiable spot, which is also close to something called the posterior commissure, and it helps you orient your brain. Then you have a not so friendly Darth Vader peeking at you here, which is your pons that I've highlighted here. My arrow is not working for some reason. Sorry, the blue region is the pons. And then you have your temporal lobe, which is extending, again, downwards inferiorly. And you start seeing the cerebellum at this stage. You start seeing the cerebellar hemispheres. Cerebellum is responsible for fine motor control, and you can easily demarcate the cerebellar hemispheres here. And you can also see the cerebellar vermis, which is not really resolved in the sagittal view, which is why I've provided a more resolved sagittal reconstruction at the top. And that occupies the medial space here in the cerebellum. And then you have your fourth ventricle, which is where CSF flows from your third ventricle into before it drains into your subarachnoid space. All right. Now, this is the last slide I have on neuroanatomy, which is basically the inferior part, which is imaged. You can see the medulla, which later becomes your spinal cord, and you can also see the cerebellar tonsils. In a normal brain scan, you're not going to see the cerebellar tonsils crowding the region, and you'll see more space. And this is also from a normal scan, and this is normal pathology. Okay, now that we've gone through a tour of neuroanatomy on CT, we've seen how a healthy brain looks. How do distinct neuropathologies appear on CT? Primarily, I wanted to show what acute traumatic brain injury looks like, which is the most prominent application of head CT. So you see on the left side that you have a patient who had seizure and bleeding from closed injury. You see a lot of acute blood. And as you may recall, I mentioned that Hounsfield units of acute blood are about 80. So it's really bright and nicely visualized. And then in the middle, you see a patient with head trauma who had a loss of consciousness. You also see an epidural hematoma, which is lenticular or like biconvex in shape. And both these images on the left represent closed head injuries. What you see on the right is how your CT scan looks when you have a penetrating head injury with a bullet wound. You see fragments of bullets in the brain, and there's also blood. Now, this is again, this is the most prominent type of acute injury that's visualized on head CT. And then there's also a couple more types of acute pathologies that are revealed on CT, which are hydrocephalus that I alluded to in the beginning when I was talking about the Sylvian fissure. If you recall, it's highly expanded here, and your midline space is almost constricted, and this is a telltale sign of hydrocephalus. And then on the right side, you see a patient with an abscess, which is also an acute condition. It's an infection. So all of these acute pathologies can be revealed on CT. I did mention that CT often gets sidelined when it comes to chronic degeneration because people prefer MRI for its higher resolution. But you can clearly see that in Alzheimer's dementia, for instance, you can see atrophy. You can see your Sylvian fissure expanded, but you can also see your midline space expanded, which is opposite to what you see in hydrocephalus, right? So there's a open problem in the field of hydrocephalus research, which is trying to identify patients who actually respond to shunt surgery, which is what people do to treat hydrocephalus. You drain that excessive CSF. You see here in the ventricles are super expanded because there's a lot of CSF in the ventricles. And what the treatment in NPH or hydrocephalus entails is you insert a shunt into the ventricles and you drain that excess fluid out. Now, we do not know which patients will respond positively to surgery versus which patients do not benefit from surgery, and becomes really important to correctly identify those patients. And it turns out that what clinicians practice very commonly today is they use something called a CSF tap test, which is they insert a needle into your spine, they drain some fluid from your CSF from your lumbar space, and then if you are improving, they get a preview of how you're going to perform if you're given a shunt. And then they decide whether to give you a shunt or not based on that spinal tap. Now, the sensitivity of this test is known to be really low. And it's also invasive and it has the risk of infection. So this is where imaging comes into play, where I think it can be a non-invasive solution in picking out which patients respond positively to shunt surgery versus which patients do not. In fact, exactly what I'm showing here is captured in a feature called disproportionately enlarged subarachnoid space hydrocephalus, or DESH in other words. So if you see very constricted spaces in the midline and enlarged Sylvian fissures, that represents a high value for the feature, it just means that there's presence of DESH in your patient. And it's been shown that this feature actually can predict how a patient responds to a shunt or not. So there's a lot of good opportunities with CT to examine chronic degeneration as well as acute degeneration. And then on the right side, you see a patient with chronic subdural hygroma, which is essentially, there was a SDH or a subdural hematoma there before, and that space has been filled with fluid, and it's probably a little bit of old blood. And you can also see that it's causing some midline shift towards the right side or the left hemisphere of the patient. Last couple of things that I want to show that are evident on CT is if you look at the image on the left, you can see a hummingbird peeking at you, which is a very common sign of progressive supranuclear palsy. You can see that this sign appears like a hummingbird, and it's shown to detect PSP really well. And then on the right side, you have a patient with frontotemporal dementia, and there's a very common finding which is called knife edge atrophy. If you look at the axial scans in the top two rows, you can see that the foldings of the brain resemble knife edges, and that is also a telltale sign of frontotemporal dementia. I alluded to a little bit of NPH before, and I want to talk to you guys about a work that I've done to detect NPH using CT. But before I get to it, I want to stop here and ask, do you have any questions, any thoughts to share with me, any feedback? or like, does this resonate with any of your research so far? Okay, somebody's nodding there. What do you work on?
Oh, this very much reminds me of I'm a new PhD student.
Okay.
This is basically what we did in so.
Oh, awesome. Thank you. Right. Anyway, so with all the imaging markers that I presented so far, I think one of the things that actually really worked for us is looking at interpretable features of ventriculomegaly in NPH. And as you can see in this image, we were able to show that using CT, we can detect NPH and classify it from other conditions like Alzheimer's dementia, post-traumatic encephalomalacia, and just a headache control. Now, this problem becomes really important because distinguishing NPH from AD is, a huge, again, problem in the field of hydrocephalus research, because people often get misdiagnosed with Alzheimer's dementia. And mind you, NPH is a reversible type of dementia, and you don't want patients living with a life sentence of having irreversible dementia due to Alzheimer's or anything. So using interpretable features that are shown here, we have 7 of them that you can see. All of these capture ventricular expansion in a sense. The first 3 columns correspond to what are called the Evans indices. So they capture how much your ventricles have expanded in the orthogonal directions X, Y, and Z in comparison to the brain. And the higher that value, you're going to see more hydrocephalus. Now, these are extremely simple variables that you can code to algorithmically extract through CT. And then in the 4th and 5th columns, you see angular, and even the 4, 5, and 6, all the 3 columns, you can see angular measures, which are basically, again, capturing how much your ventricles have expanded and how much they're squishing the brain in a way. And then the final column represents the 3rd ventricle width. So with all of these features, we were able to show that NPH can be distinguished from its mimics and headache controls with good accuracy. And I hope that this demonstrates the utility of head CT in screening for neurological diseases, especially chronic conditions, and also gives you a good introduction into what CT image processing in neurological healthcare looks like. I think that's all I had. Here are the references. And let me know if you have any questions. Yeah.
Yes. Yeah, thank you so much for your presentation. It was definitely insightful. I did work on an ALS project, and so I'm trying to see like what I could get from this that would be useful in that.
Yeah.
And so my first question is, are there any specific biomarkers that used within this study? Is there a way that we could find biomarkers for like other neurodegenerative disease, like amyotrophic lateral sclerosis, ALS? So with those biomarkers, we are able to then find drugs that could treat that. So are there any like specific biomarkers that could be derived from using this in another neurodegenerative
Yeah, so I am not particularly familiar with ALS, but I appreciate your question, and I can answer it, based on my experience with other neurodegenerative diseases. So absolutely, yes. First of all, if the first thing I would do in using CT for this kind of work is just do literature survey, gather what information there is in terms of already known and established markers for that disease. And then if you feel like some of these are interpretable, then the next thing you do is which anatomy do they correspond to? And then visualize them on CT and see if you can derive proxy measures. So I want to give you actually an example with this question. So if you focus on the column, not the last column, but the column next to it. So the second column from the last, right? You can see that there's this angle which is subtended between the occipital horns of the lateral ventricles. It's represented, I call it phi. Are you able to see that, like this angle? Like this one, the one that I'm pointing to right there. So this one was actually a proxy measure. And by that, I mean there's something called the splenial angle, which measures the angle between the major forceps of your corpus callosum. And that's white matter. You can't image that on CT. It's not at all evident, So what we do is you see the occipital horns of the lateral ventricles, and your forceps measure, or the original thing that the feature measures, which is the forceps measure, they stick to your occipital horns really well. So they actually follow that path really well. And the ventricles are very well imaged on CT. So what if you measure that angle instead? And that's what we've done. And it turns out it correlated to the white matter measure really well. So that means you can find proxies like this. So you identify your anatomy of interest and then see if you can measure it on CT. Another thing you can think of is, if it's not easy to extract using domain knowledge, you do something with regions of interest. Like if for instance, I don't have a picture here quickly, but maybe let's take that, right? The hummingbird sign in progressive supranuclear palsy, like just on the left side. And imagine you have a region of interest that you've identified. What you can do is you can crop that part out and do some feature extraction with it. You can look at shape features. Charlie's going to be talking about that later. Some textural features, morphological features, and see if you can use those to build your algorithms. Yes, so there's definitely a way to do that, to integrate domain knowledge into your question. Now, if there's absolutely no work on looking at what the radiological markers of ALS are, then you're going to, I think you're faced with a bigger challenge. You might try a more unsupervised approach, maybe using deep learning or other methods. Thank you.
Okay, thank you for your answer. You've said a whole lot, and I have a lot to think about. So just to put that in one sentence, does it sound like you're using all these different, more morphological based biomarkers to then do like an integration with omics? Is that like the direction there?
So I do not work in omics at all, but you should definitely do that.
Okay. I mean, that's what it sounds like. I'm just putting the words to it.
Yeah. No, you should definitely think about integrating multimodal data. I think that's where we're all heading. But
Okay, thank you so much.
Thank you.
Hi.
Hi.
Is the mic working? Yes, it is. Okay. Thank you for a fantastic talk. This was really awesome. I love neuroanatomy, so this is like really something that speaks to my interests. My question is, a lot of the pathologies that you can view on CT are evident. For example, if the hemorrhages or hematomas are very clear to see, or frontotemporal dementia has very clear signs. Do you see improvements in the field happening to visualize more subtle pathologies that typically you'd use MRI to look at? And if so, where do you think the field is moving?
No, that's an awesome question. Thank you. And this also actually ties to one of my recent projects, and I can talk about that. So in terms of what the field is like, how accommodative they are about using CT versus MRI. I think there's still a lot of inertia in terms of adopting CT, because obviously there's a lot of limitations. The resolution's not good. The gray matter, white matter contrast is not good. And, you obviously want to go to an MRI. But in situations where you don't have access to an MRI, CT is definitely the way, and it's acquired in large volumes. So it'll especially be suited for like data-driven analysis. Now, going back to your question about like, are there any advances in the field, right, which helps us maybe look at CT more? I feel like, yes, in terms of technological optimization, like how CT is acquired, we're getting more crisp images, more highly resolved images at lower radiation doses. So obviously, yes, in the future, I think there's going to be a huge opportunity that'll open up to start implementing a lot of CT-based analysis. I'm sorry, can you remind me? You had there was one more part to your question.
You're actually answering it, but I was wondering like where you think the field is moving.
Yes. No, I do definitely think that we're going to see a lot of advances with CT that will allow us to develop these things in a more accessible way. And just the last point I wanted to mention is, in one of our recent projects, we're looking at identifying the anterior and posterior commissures on CT. And, it's one of the most frequent comments that I get when I present this work is, we don't use CT for this. We use MRI. Just like they shun the work. But again, we've shown that it performs really well, and there is an opportunity there, which unfortunately is missed when people don't take the chance. And like what we've done to solve that problem is we have a deep learning solution. So yes, I definitely think there's a lot more we can do with CT that we're already not doing. Thank you.
Thank you.
Thanks.